Good afternoon. Thank you for coming. My name is John Crenny, and I'm a student at Excelsior College. This is my capstone project. Angela Jourdain was nice enough to facilitate, to mentor me into this offering entitled Integration of Behavioral Health Assessment in Primary Health Care. The purpose of this learning module is to provide education to care coordinators experienced in the behavioral health sciences with medical conditions affecting those clients with mental illness. Our objectives today will be to understand the role of the care coordinator in the management of clients with comorbid conditions, determine the risk factors of diabetes, recognize the signs and symptoms of diabetes, differentiate medications commonly used for diabetes, and discuss ways to reduce the problem of diabetes. Comorbidity is the occurrence of mental and physical disorders in the same person. According to data from the 2001-2003 National Comorbidity Survey, 34 million American adults, or 17% of the adult population, had mental and medical conditions within a 12-month period. Care coordinators provide patient education, aid patient decision-making, monitor symptoms, and communicate with the team. The medical disorders that I'll be discussing with you today is diabetes. It is the 8th leading cause of death in the United States. And diabetes is one of those illnesses that affects patients with mental disorders such as depression, anxiety, schizophrenia, and bipolar disorders. Diabetes is a group of physiological dysfunctions characterized by hyperglycemia or high blood sugar, resulting directly from insulin resistance, metabolic syndrome, or inadequate insulin secretion, or excessive glucagon secretion. Diabetes was diagnosed in 29 million Americans in 2012. Nearly 3 times that many are pre-diabetic. Diabetics have a 2 to 4 times greater risk of developing comorbid depression. And 50 to 80% of people with diabetes have a knowledge deficit about the disease. Some of the signs and symptoms of diabetes include hyperglycemia or high blood sugar. High blood sugar would be 180 milligrams per deciliter. Okay. With that, you'll have frequent urination, okay, excessive thirst, weight loss, and blurry visions. Okay. Hypoglycemia or low blood sugar, okay, is blood sugar less than 70 milligrams per deciliter. And with that, you'll see signs of drowsiness, weakness, dizziness, confusion, irritability, hunger, a rapid heartbeat, sweating, shaking, and feeling jittery. Diabetic ketoacidosis is a serious condition that can lead to a diabetic coma. It occurs more often in type 1 diabetes. Glucose is the body's normal source of energy. Cells break down fat for energy in the absence of glucose, and ketones are a product of fat metabolism. Some of the risk factors for type 2 diabetes are obesity, physical inactivity, having a first-degree relative with diabetes, race and ethnicity, African Americans, Latinos, Native Americans, Asian Americans, and Pacific Islanders are also at higher risk. Women who have delivered a baby weighing more than 9 pounds, and those diagnosed with gestational diabetes. Okay, so in type 1 diabetes, previously called insulin-dependent diabetes or juvenile diabetes, it would occur around the age of 13. Okay, it's caused by a destruction of beta cells in the pancreas, which is where the insulin is produced. So insulin is produced in the pancreas. Okay, it's usually destroyed through an autoimmune disease. Okay, and they can no longer produce insulin. They must have insulin injection or a pump for the rest of their life. Now, type 2 diabetes mellitus, previously known as non-insulin dependent or adult onset diabetes because it occurred later in life, accounts for about 90 to 95% of all cases of diabetes. It's due mostly to insulin resistance and lack of insulin secretion. Then there's gestational diabetes. It's a form of glucose intolerance diagnosed during the second, third trimester of pregnancy. It affects 5 to 10% of women. 5 to 10% of women will become type 2 diabetics after their gestational diabetes, and they are at risk for recurrent gestational diabetes with future pregnancies, and their children are also at risk for developing diabetes. So when we have a diabetic patient, it's very important that the patient know their numbers, okay? And we have several methods of testing, but the primary test used for disease management and research is the hemoglobin A1C. Now, glucose attaches to the hemoglobin, which is the protein in the red blood cells that carries oxygen. The blood cells regenerate approximately every 3 months. Thus, hemoglobin A1C test reflects the glucose level over the past 3 months. Okay, it does not require fasting, and blood can be drawn any time of the day. It's recommended minimum twice a year for clients reaching their treatment goals, and quarterly for clients whose therapy has changed or who are not meeting their treatment goals. The treatment goals are individual, but a normal hemoglobin A1C is less than 5.7. Another method of verifying blood glucose level is through the finger stick blood glucose. Okay, the frequency and the timing varies according to the type of diabetes, type 1 versus type 2, and the medications that the client is on, insulin versus an oral anti-diabetic. Common times for checking blood sugar is upon awakening, right before a meal, with the target of between 100 and 130. 2 hours after a meal. Now the term postprandial refers to after a meal. Prandial has to do with a meal. So prandial is with the meal, postprandial is after the meal. And that should be no more than 180 milligrams per deciliter. And then right before bed. There's a dawning effect, which is a phenomenon whereby blood glucose levels in the early morning hours are high. Okay, the finger stick can be used, the finger stick blood sugar can be used to adjust food intake, exercise, or pharmacological therapy to achieve treatment goals. Some of the complications of diabetes: the cardiovascular system is a series of the heart and the blood vessels, and they're very sensitive to insulin levels in the body, and over time diabetes can cause hypertension, which in turn can lead to stroke and heart attack. Part of the diabetic management is controlling blood pressure and other issues that relate to heart disease. It can also cause tooth loss, tooth decay, non-healing wounds. Patients who are diabetic are at 10 times greater risk of amputation. It affects immune function. That's why it's important to remind the client of their yearly immunizations against pneumonia and the flu. It can also cause what they call diabetic neuropathy, or a loss of sensation or numbness, loss of temperature sensation, which leads to the ulcers and loss of fine movements. It's the leading cause of blindness in adults. Okay. Pregnancy, it can cause the birth of rather large babies who are at risk of developing diabetes. Okay. And it also affects the kidneys or the renal system, leading to kidney failure in many cases. Psychiatric problems: the prevalence of type 2 diabetes is twofold, 2 to 3 times higher in people with schizophrenia, bipolar disorder, and schizoaffective disorder than in the general population. Skeletal blah blah blah. I mentioned diabetic ketoacidosis already. It can also contribute to the development of cancer growth. It may also affect medications that a person is taking, causing adverse drug reactions. So one of the ways in which we can help control the disease of diabetes is through nutrition. Now, it's recommended by the American Diabetic Association that a person with diabetes goes to see a dietitian who is expert in diabetes. It's recommended that a person eats in a way that supports tight glycemic control, meaning keeps their blood glucose levels close to their target. It's also recommended that physical activity be done at least 5 times a week for 30 minutes. And here's something I never heard before. Avoid remaining stationary for 90 minutes at one time. Wow. Okay. And then there's pharmacological interventions. Now when I say monotherapy, that means that the person is put on a medication. Dual therapy, the one medication isn't bringing the person to target, and they start a second medication. Sometimes there's as many as 3 medications required to bring the blood glucose levels down to the target. Okay. We get on in the development of these new products, the cost goes up. You know, the metformin and the glucotrol, they've been around for a long time, so the costs associated with those drugs are far less than those of the newer drugs. So lastly, we have insulin. Okay, insulin is used usually in combination with other drugs, okay, as part of that dual therapy or triple therapy. And this also requires training, okay, because the patient has to administer it 5 to 10 minutes before a meal. They have to know that it's peak in 1 to 3 hours, and that it's only going to last up to 5 hours. Okay. But because it's a rapid acting, okay, it'll probably start to work in 10 to 20 minutes. Okay, now here we have, most of these are 100 units per ml. Okay. Now what if you're taking 500 units, like here? Okay. Isn't it better to have 500 units in 1 ml than have to put in 5 mLs? Yes. So again, a lot of the newer insulin developments are being promoted as more units in less volume. Okay, they have 200 and 300 and 500 units per ml. Okay, so you have rapid acting that can start to work in 10 to 20 minutes, even up to a half an hour. Then you have the short acting, which will only last from 4 to 8 hours. And then here you have 16 to 24 hours. And here's, again, this takes about 2 hours to start. Okay, and we've all heard of Aventis, right? 24 hours, okay? And you don't have to worry about your meals. Okay? It's not done in correlation to your meals. So the non-compliance to the treatment plan, because there's several barriers. One is hypoglycemia. Okay, we talked about hypoglycemia earlier, where there's many side effects. And we talked about weight gain, we talked about the different side effects, the gas, the swelling, rapid heart rate, the pain. We also mentioned the costs, you know, $20 copays, each medication every month adds up. When I say health literacy, I mean that patients will be able to understand and repeat back to you what exactly they are supposed to do. Okay? In the hospital, we used to use the teach back method. So you would explain something to the patient, and then you would ask them to tell you in your own words, like what you just said to them, so that you knew that they understand. It's amazing that there's usually a very big gap. You know, they might retain maybe 50% of what you told them. Okay, so another reason for the non-compliance to the treatment plan is that you have very complex regimes. Like you might be taking an oral anti-diabetic medication 2 or 3 times a day, plus an injectable at your meals, and it can be very overwhelming and confusing at times. Okay, that's why there's a 40% of patients that don't adhere to their diabetic medication. Only 1/3 of the patients take their insulin as prescribed. And patients with diabetes who do not take their medicine consistently are 2.5 times more likely to be hospitalized. Thank you.